you can start now.
Okay, started. You're off
Candidate
now.
1.
Yes.
Yeah, so this is a 70-year-old patient who has presented with arm pain, right arm pain.
Frontal radiograph of the right shoulder.
Candidate 1, sorry to interrupt you there. Please be a bit louder.
Okay. Is it okay like this?
Yeah, much better. Yeah.
Okay. Frontal radiograph, right shoulder, showing normal bone density with no fracture line, mild acromioclavicular arthritic changes with calcific tendinopathy as the insertion of the supraspinatus. I'm checking, I find there is a bony lesion of the right aspect of rib at the posterolateral aspect that's seen a wide zone of transition and seem to be expanded with bony lesion and associated extra pulmonary soft tissue opacity is noted. In my routine practice, I'm checking if there is any previous history because and I will recommend dedicated study for chest radiograph to narrow my differential, which is maybe brown tumor, maybe in chondroma, maybe fibrous dysplasia or metastasis, and informing treating clinician for next step.
Okay, this patient has presented with arm pain. So would you like to have a look at the humerus?
Again, patient presented with
arm pain. There's a pain in the arm.
Pain in the arm. In my routine practice, upon this clinical presentation, still I should see other orthogonal view to check if any associated fracture or injury. And also because there is mild arthritic changes not matching with patient age and calcific tendinopathy along with the supraspinatus tendon as well. So I need to further investigate and lateral view, also other orthogonal view to check for the right arm.
Okay, I'm not having any orthogonal view right now, but the orthogonal view was showing some periostal reaction along the upper shaft of the humerus.
Yes, here again I'm review. I find that the mid shaft shows mild periosteal reaction along the diaphysis bilaterally. Still I don't see exactly, and there is subtle ground glass opacity seen along the medulla. So I'm worried to be fibrous dysplasia. So I recommend to.
This is a 70-year-old patient.
70. I'm worried to be metastatic lesion or because this rib lesion, I'm worried of metastasis.
This is a middle-aged patient who had presented with there was a cerebral abscess and the patient was being investigated.
Frontal radiograph of chest of skeletal mature patient. The left mid-lung zone shows lobulated opacities is seen with linear opacity extending to the hilum. Associated with no pneumothorax or pleural effusion could be detected. No mediastinal. Upon this history, I'm worried about pulmonary AVM, arteriovenous malformation. So I would check previous, if any available previous imaging and further CT chest with contrast and ultrasound to check if there is associated hereditary hemorrhagic telangiectasia. This CTI can scroll.
Wait a minute, sorry, I think.
Yeah, meanwhile, sorry to interrupt. Candidate 1, please be a bit louder, because though we can still somehow hear you properly, but we'll have problems with the recording later on.
Okay.
I have given you the control.
Okay. I can't scroll.
Yeah, there are single images, certain single images, I think.
Oh, static images only? Okay. This is static images, some selected image of chest, confirmed the presence of vascular structure seen at the left lung with a vascular channel extending from pulmonary vessels. Also, the right lung zone shows also vascular structure. So upon this, I'm associated with mild atelectatic band in the lower lung. In my routine practice, I'm checking lung window as well. No associated liver vascular lesion upon this selected image. So it is multiple pulmonary avascular necrosis, venous malformation.
Okay, so what will you do further?
I'm urgently informing the treating clinician about the condition and further investigate the MR brain, because this is patient susceptible to stroke or brain abscess for and dedicated MRI for the patient brain.
There was a concern for bone stress fracture for this patient. The patient is a young patient, 25-year-old, and he is complaining of pain in the knee joint. That's why this nuclear imaging was done.
Okay. Bone scan showing uptake of the kidney. Otherwise, there is uptake seen as the right aspect of the medial aspect of the distal femur, focal increase uptake. Otherwise, no definite bony uptake. I can check also posteriorly as confirmed the same. In my routine practice, I'm checking a radiograph of the same patient to correlate with it. Frontal radiographs of the same patient, which shows avidly enhanced, avid uptake. There is subtle, no definite bony fracture could be detected. It is subtle lytic lesion is seen with seems to be non-sclerotic margin eccentric, no cortical destruction, with wide zone of transition medially, laterally. It's not reaching the articular surface. I'm worried to be differential of maybe bony angioplastic process, but less possibility, maybe fibrous dysplasia, maybe
patient is a 25-year-old. What will you what differential diagnosis will you expect?
25. I'm worried about also if any manifestation of osteomyelitis of this patient. So I need to correlate presentation and further MRI of this case for characterize. This is seem to be a non-aggressive bony lesion. Maybe from this age, maybe eosinophilic granuloma, maybe a brown tumor. So I need to correlate any previous history and further MRI of this case. I can scroll.
And I think that is a static image.
Coronal fast imaging showing intermediate hyper to hyper signal intensity of the previously noted lesion with area of cortical breaching and periosteal reaction and subperiosteal edema is noted associated with bony edema. I'm worried about osteomyelitis as well because of edema. I need to check contrast enhancement in my routine practice. So because to exclude the emergency and correlate with any clinical manifestation of the patient of inflammation or inflammatory marker. Also, I will recommend biopsy of this case.
What will be your differential diagnosis for such an eccentrically located lesion in this age group?
In this age group, it may be the differential is upon this location. In age group, it may be chondroblastoma, but it should be sclerotic margin, so I'm not with it. Maybe bone tumor, maybe Bruder's abscess, maybe eosinophilic granuloma also. So my differential I couldn't define exactly.
Okay. This patient is having upper abdominal discomfort. You can scroll the images.
CT abdomen of the patient complaining with abdominal discomfort. I'm taking overview. I find there is a sizable focal hepatic lesion is seen as the segment 2 and 4A, heterogeneously enhancing, and the seen extended segment 3 as well. The liver, no signs of cirrhosis, no pathologically enlarged lymph node could be detected. The both adrenal it seems to be subtle right, bulky right adrenal gland, otherwise normal. No thrombosis. I'm worried if there is concentric thickening of the ascending colon.
Ignore that. That is because of the collapse.
So this presentation, I don't find any associated lesion. In my routine practice in focal hepatic lesion in its venous phase, I'm checking arterial and late phase as well for characterization of the lesion. But maybe this is differential, maybe adenoma focal nodular hyperplasia, metastasis, or maybe it's like fibrolamellar HC.
Okay, so MRI was performed to further characterize this lesion.
MRI of this patient T2. I can scroll between the sequence or only T2?
Yes, you can scroll between the sequences.
T2 shows a heterogeneous mixed high and intermediate signal intensity with area of cystic changes. Arterial phase shows peripheral enhancement, heterogeneous peripheral enhancement. I couldn't detect any other focal hepatic lesion. And delayed gradual accumulation of contrast in the delayed phase. There is diffusion. I'm checking its hyperintensity area. I check with EDC. Areas inside of diffusion restriction. So I'm worried about fibrolamellar HCC of this case or cholangiocarcinoma. So I would like to correlate with alpha-P2 protein and further biopsy of the case.
Last minute left, 1 minute.
Okay. 40-year-old patient who is having recurrent urinary tract infections.
Dr. Swati, sorry to interrupt there, but this should be the last case, please.
Yeah, this is the
Thank you.
Axial T2 of the patient presented with recurrent urinary tract infection showing dilated urethra. I'm going to check the sagittal. The cystic-like structure is seen within the prostate. It's seen within the prostatic. I'm worried about prostatitis. So I like to check contrast enhanced associated. There is soft tissue thickening and irregularity also the seen within this area. So I'm worried in this presentation to be a prostatitis. So I'm checking contrast enhancing as well to check this soft tissue thickening. Is it enhancing component to be worried of any malignancy or not? And urgently informing a clinician if there is upon my suspicion for urgent management.
Okay. I think Dr. Sandeep, I'm done.
Yeah, thank you so much.
Yeah,
so, yeah, we could complete the cases now.
Yeah. Candidate 1, just be attentive. Especially, I could make it out that you could not get this case. Especially when I gave you the hint, this is a female patient. You should have immediately changed course.
Yes.
Okay, and this actually case has a very different set of differential diagnosis. I think you have to work over differential diagnosis, this thing. The finding and differential diagnosis. So being a female patient, I think the differential diagnosis changes completely in this case, right?
Yes, true.
Okay, so just be attentive when you are looking at the scan and be prepared with your differential diagnosis list. This was a case of urethral diverticulum, of a common presentation in a female patient, like mid-urethral level, and there was a differential diagnosis list of a vaginal cyst, periurethral skinny gland cyst. So it was a different case, truly speaking. Then in this patient, you picked up the findings very well. It's a fibrolamellar HCC. You gave the differential diagnosis also very well, the metastasis and cholangiocarcinoma. Okay, this patient, I think you need to work over the differential diagnosis list of the bone entities which will occur in that particular age group. Especially when you're seeing this kind of I gave you hint also twice that it's an eccentric lesion. So whenever you see an eccentric lesion, ABC, GCT, all this kind of stuff should come in 25-year-old. You said non-sclerotic border. with non-sclerotic border, it is usually GCP. So, so your, I think the description was right, but the differential diagnosis list needs to be worked out. And this case, yeah, this was bang on. This was absolutely right.
Yeah, so could we please go through the diagnosis, because some of the
Okay, so this was
want
pulmonary AV malformation. This was the pulmonary AV malformation case. Multiple AV malformations were there, and as I had given the history, this patient had a cerebral abscess. So we know that this was because of the right to left shunt kind of thing, and she rightly said that she will look at the liver and to rule out for Osser-Weber-Rindau syndrome. So this was a vascular malformation, and this case, I think when a 70-year-old patient with arm pain, you should start first looking at the, the concerned part first. You definitely picked up this finding. This finding is there is a lesion in the lung, which is a primary actually, and there is a lytic lesion over here in the arm, in the diaphysis, which is a metastasis. Okay, so be attentive, and especially when examiner is giving you hint that there is some, I gave you the hint also that there's some periostral reaction. So, just be attentive to the hint, as well as be attentive to the clinical scenario. I think if you once put the clinical scenario in picture rightly, you will be able to come to the diagnosis properly. You picked up this finding very well. So when you had said this, even if you had said this as a metastasis, and then you would have looked for the arm, it would be an arm pain, like it would be a metastasis region over there. Okay, this was the primary, and this was the metastasis.
Okay, thank you.
Thank you so much, Dr. Swati, and very good collection of cases, especially the first one, because these are the kind of cases that they usually show in the exam. So you'll have some straightforward cases, but then make sure that you're looking at the corner of the screen and the corner of the scan. So that is important as well. Do you want to add anything else, Dr. Swati, for candidate 1?
No, nothing else. I think you're doing good. Just pick up the keep yourself calm, pick up the findings well, and give a differential diagnosis list properly in that clinical perspective.
Okay, thank you.
So that is actually a very good tip, that is to keep calm. I understand it is not always possible to keep calm in such a situation, but there is no other choice for us to at least try to keep calm during that 1 hour. So that 1 hour will be the decider for your pass or a fail. And I'm sure almost all the candidates, or all the candidates actually, that are appearing for the March exam will pass from our group. So candidate 1, I'll give you a few positive points about you and a negative points about you. The first positive point, that you're confident when you know the findings, and even when you're not confident, you keep on speaking. So you are verbalizing about the cases. That is very good. You have good knowledge, and that is again very good. But few bad points which you should correct. We still have 1 week, and that is regarding the differential. So in the actual exam, and even in any radiology viva exam, it is not always correct to give a very wide range of differentials. Even if you know the entire Chapman book or the top 3 differentials book by heart, it is not good to keep on speaking about 7 or 8 or 10 differentials. So even if you give them 3 or 4 differentials, the RCR examiners will always ask you for the final diagnosis. Like in one of my cases in my exam, I finally gave them 2 diagnoses where I was not sure about the final diagnosis. So I gave them 2 differentials. Even after that, the examiner kept on telling me, I want the final diagnosis. Among these 2, which one do you prefer? So they will poke you, and they will want the final diagnosis out of you. So try to narrow it down, and not give a very varied range of differentials. And apart from that, you have to complete the management. Few of the cases today, Dr. Swati actually had to prompt you regarding the management. In the exam, they might not even prompt you. They might just change the case, and you've lost the marks for the management part.
Oh, yes.
There are marks for each and everything. There are marks for describing the image. There are marks for identifying what scan it is, whether it's a radiograph, whether it's a CT of contrast, non-contrast, For describing, for differentials, for management, there are marks for everything. So you have to know that and answer that. And the last thing,
yes.
like this is something which differs for every one of us. So if you can be a bit more enthusiastic during the exam, like for every candidate, it's always better to sound a bit enthusiastic. Now, I don't think this really matters, but then some of the examiners will actually prefer that you're enthusiastic about the cases and you're taking them head on. So that is one thing. Regarding the scrolling, this is not for you. This is just a general tip. If you're not describing that particular image or that particular case and you're just speaking about the management, leave the mouse.
Yes.
Some of the candidates, this is not about you, candidate one. This is like, even I used to do this. Like after I've completed describing a case and I am onto the management, but my right hand is still scrolling the case. So we have to remember that during the actual exam, the examiner one who is showing you the case is not the person who is marking you. It's the examiner two. So they are observing each and everything which you are doing. So let us avoid scrolling to and fro unnecessarily. Other than that, you did well. I would give you a 6 or a 6.5. So you've passed. And you definitely need to work on few things which Dr. Swati pointed out. Other than that, well done. So thank you so much. Thank you, Dr. Swati.
Thank you.
Yep.
Thank you so much.
Thank you. And now we have
No.
C2. So candidate 2 is named C2.
Yes.
Are you there with us?
Yeah, I'm here.
Yeah.
Yeah,
so
stop sharing.
yes, please, ma'am. Yeah. So I will start sharing my screen and I will set the timer. Please give me a moment. Yes. So can you see my screen, candidate 2?
Yeah,
C2?
I can see.
Can you see an
Yes.
elbow radiograph?
Yes.
So I'll set the timer. Meanwhile, you can keep looking at it. And then you can start speaking now.
Okay, I'm presented with an elbow radiograph lateral view for a skeletally immature patient. I cannot appreciate the side marker on this view. So I can see an elevated anterior fat pad with positive posterior fat pad sign denoting joint effusion. Now I will look for any intra-articular fracture. Actually, I cannot appreciate any definite lucent line on this view. So in my routine practice, I would like to check the other view, the frontal view, for any fracture line.
Okay, the orthogonal view did not show any fracture. What would you do next?
Okay, so I will pick up the phone and urgently inform the referring the referring physician that there's joint effusion and most probably there's an intra-articular fracture, but it's subtle here, but I cannot appreciate it here. So patient should be treated as if he has a fracture and follow-up X-ray will be done.
Okay. Have a look at this case, please.
Okay. So this is frontal X-ray for a foot for a skeletally mature patient. Okay. First, I will trace the cortices of every bone I can see to check for any fractures. Okay, I can appreciate focal fusiform shape area of periosteal of solid periosteal reaction.
Could you point us where you're indicating? You can use the mouse.
Yeah,
fracture
I have
Dr.
to.
Venkatesh, please, this is not your viva. Please mute yourself. Otherwise, I'll have to remove you from the session, please. Dr. Venkatesh, yeah. Thank you so much. Yeah, please go ahead.
I have to share the screen first, or you can see the mouse, or I have to share the screen.
Yeah. So you have the screen
So
control,
you can
right?
see?
Yeah, I can see what you're pointing out.
Yes.
Yeah, just
Okay,
ignore that. Ignore it. Please ignore that.
Okay.
That was normal.
Okay. So I will continue checking the bones. I can appreciate a subtle lucent line at the base of the fifth metatarsal, which is reaching the cortex. So this is suspicious for a non-displaced fracture. I would like to confirm on the other view and to correlate clinically with the area of tenderness for the patient. Okay, so here the fracture is more evident. So it's a hairline, not displaced fracture involving the base of the left fifth metatarsal. I will pick up the phone and inform the referring clinician about my finding.
Okay, have a look at this case, please.
Okay, this is the bilateral knee X-ray frontal views for a skeletally mature patient. I can appreciate evidence of multiple bony exostosis involving the right distal femur and left proximal tibia. Okay, they are seen mainly at metaphyseal region, going away from the joint space, and there's continuous medullary cavity within them. So I'm suspecting multiple osteochondromas. I cannot appreciate evidence of soft tissue swelling surrounding them, any cortical break or pathological fracture, or even any lucencies. So I think this is a case of diaphyseal A classes. I would like to correlate with previous images to check if the patient is a known case, and if so, I would like to check for any change concerning for malignancy. I would like to know the clinical history of the patient, if he has pain or any symptoms that's concerning for malignancy. And if this is a new case, I would like to go for MRI, or if there's any change from previous, I would like to go for MRI to check for the chondroid cap. If it's more than 1.5, then I will be concerning for malignant transformation.
Okay, what is the percentage of malignant transformation in this case?
Because it's multiple, it's from 5 to 25%.
Okay, and
more than solitary.
Other than the finding of thickened cartilage cap on MRI, any other finding which would point towards malignant transformation?
On MRI, yes. Cartilage cap, new enhancement, enlarging new soft tissue mass surrounding it, or any cortical breakthrough. This is on MRI. On scintigraphy, if there is any new uptake without fracture.
If this presents with enchondromatosis, what is it called?
Multiple enchondromas, Ollier disease.
No, if this finding, if diaphyseal achalasis also has multiple enchondromas.
I don't know actually.
Okay. Have a look at this case, please.
Okay, this is the contrast swallow for a patient frontal view showing the esophagus, showing contrast in the esophagus and starting to fill the stomach. I can appreciate the evidence of proximal wide distension of the thoracic esophagus with multiple indentations seen at the distal thoracic esophagus down to the gastroesophageal junctions. They are more or less smooth indentations causing the proximal dilatation. They are giving the corkscrew appearance. Although they are causing narrowing, but there's contrast flow into the stomach. So this is a case of diffuse esophageal spasm.
So what would you do next?
And I cannot see any malignant structures to suggest for malignancy. I would like to convey my findings to the treating physician, and after checking the other views and the whole study for further evaluation. Here,
have a look at this case, please.
My recommend manual. Okay, here this is CT
this
scan.
Patient came to us with acute pain abdomen.
Okay, this is CT scan coronal view for a skeletally mature patient. First, I can appreciate diffusely sclerotic bone involving the visualized bones, the spine and the iliac and both femur bones, with some heterogeneity at the left iliac bone. Otherwise, I can see, okay, the L1 vertebral body showing biconcave end plates, suggesting the H-shaped vertebra. The right femur head showing sclerosis, fragmentation.
Could you please point out the findings once again? You have the control.
Okay, so generalized diffuse sclerosis, heterogeneity in the left
We actually cannot
iliac
see your screen, see your cursor. So could you please control the mouse? I've given you the option to control.
I have the option. They said it's with me.
Just click on the image. Yeah, now you have it. Could you please point out which vertebra looks biconcave to you? Okay, that one. Okay, and what?
Okay, and heterogeneous left iliac bone with diffuse sclerosis of the bones.
Okay.
Also, the right femur is showing the sclerosis, fragmentation, and irregularities at the right femur head. Left femur head is unremarkable to me, and I can appreciate. Actually, I'm not sure if this is stomach. Maybe this stomach because
no, that is not the stomach.
The spleen. So this is the spleen, which is showing massive splenomegaly. So in summary, I have the splenomegaly, H-shaped vertebrae, multiple bony sclerosis, in addition to avascular necrosis of the right femur head. So collectively, this is a case of sickle cell disease with complicated by avascular necrosis of the right femur head. Other differentials could be a thalassemia, but it's less likely to give a H-shaped vertebra. So I will correlate my findings with the treating physician and check if this is a new diagnosis.
Okay. Have a look at this case, please.
Okay. So this is lateral, this is couch X-ray for CT scan of the skull. I can see evidence of curvilinear.
Is this an adult patient or a pediatric patient?
No, it's pediatrics because fontanelles are still open. I can appreciate evidence of calvarial thickening seen involving the whole calvarium, mostly at parietal and occipital lesions, in addition to multiple curvilinear calcifications seen in...
Which ones? Could you please point it out to us?
Those. They are taking the shape of
Which ones?
the cortical.
Are you speaking about these?
Sorry. Yes,
yeah,
you can
ahead.
see my one. Okay, so I can see so calvarian thickening in addition to multiple curvilinear calcifications taking the shape of the cortical gyri in a young patient. So I suspect a case of Sturge-Weber disease. I would like to convey my findings to the treating physician and check if there is if it's known or for previous CT scan or MRI to check for other findings like atrophy of the hemisphere with the choroid plexus enlargement.
Okay, have a look at this case, please. You can scroll if you want. Yeah, you'll have to scroll. So please scroll. Yeah.
No, sorry.
Yeah, just.
I used the right and left instead.
Okay. I'll do it for you. Never mind.
Okay.
Never mind. So the history is headache, and you're good to go. You can scroll.
Okay, up and down. Yes, it's correct. Okay, so this is a CT scan without contrast for a patient who presented with headache. I'll start scrolling from down to up. I will take a general look. Okay, I can appreciate many foci of hypodensities seen along the falx. Okay, anteriorly and also about in the right, abutting the falx from the right side. For me, they look a fat density. However, I would like to confirm with by measuring the HU unit in my normal practice. Okay, I'm looking for any intraventricular foci as well.
Okay, so what is your diagnosis?
So this is a case of ruptured dermoid cyst. I will convey my finding to the treating physician because this may cause a chemical inflammation. So I will pick up the phone and call the treating physician for the neurosurgical referral.
Okay, will you pick up the phone quickly, urgently, or can you delay for 2 hours or 3 hours or maybe a day?
No, quickly, immediately, I think.
Okay. I'll just show you the MRI for this case.
Okay.
Just describe the findings on this axial T1 sequence and then we'll wrap up this case quickly.
Okay. So here again, seen high intensity of the mass on T1. So this supports that it's a fat intensity. It's seen at the right, I think, I'm not sure of the exact location actually, but also multiple hyperintense foci seen also within the subarachnoid cisterns and along the falx. So it's a ruptured dermoid cyst.
Okay. Describe this image.
Okay, this is ultrasound scan for the right testicle, showing evidence of intratesticular mass, which shows alternating echogenic bands or circles. The mass is well defined, rounded, seen inside the testicle with no extension outside it. So this is a classic case for intratesticular dermoid cyst. I would like to check to complete scanning the other views of the ultrasound and check the left side, and I will correlate my findings with the treating physician and tell them about the mass with urology referral.
Okay, other than looking at the left testis, what else would you do in this particular
I can
lesion?
put color Doppler, but it's usually hypo enhancing.
So would you be sure without putting color Doppler that it's usually hypo, so we'll just assume that it's hypo?
No, I have to ask for color.
Okay, so what would you do next?
I will convey my finding to the treating physician and ask for urology consultation.
Okay. I will show you the last case for you today, and this is a straightforward simple case. Please describe the findings quickly.
Okay, so this is the sagittal T2 sequence of the cervical spine MRI, showing first I can appreciate evidence of tonsillar herniation below the foramen magnum, in addition to herniation and elongation of the medulla, crowding the craniocervical junction. Regarding the cervical cord, I can see multiple longitudinal areas of hyperintensity seen within the cord. So it's likely syrinx. So otherwise, I cannot appreciate evidence of cervical spine fusion to suggest associated Klippel-Fehl anomaly. This is, for me, this is a case of Chiari-1 malformation. I would like to check other sequences and to go for brain MRI with contrast to check for brain MRI to check for associated hydrocephalus and convey my finding to the treating physician and ask for neurosurgical referral.
Okay, other than looking at the brain and the other sequence for the cervical spine, anything else you would like to do?
Whole spine MRI.
Why?
For the associated vertebral segmentational anomalies or a tethered cord.
Or?
Tethered cord.
Or anything else?
No, I'm not sure.
So what are the type of Chiari malformations that you know of?
Chiari-2.
Yeah, so what do you see in that?
I see Z-shaped brainstem with elongation of the fourth ventricle, absence of agenesis of the corpus callosum, and the meningomyelocele, hydrocephalus, and cuffing of the cerebellum.
Okay, good. So we'll wrap up the cases for you. Well done, candidate 2. You're very clear and confident, I'll just go through the cases and then give you the feedback. So this was a simple case. Sometimes they'll give you this case as the first case to just warm you up. So this is a Chiari-1 malformation. There is peg-like descent of the cerebellar tonsils, crowding of the foramen magnum, and there is a long segment syrinx as well. And you are right about saying that you would look for hydrocephalus in the brain, and you also have to look at the entire spine for any associated findings. You should also look for any myelomeningocele in such cases. So well done with this case. And you were also perfect in saying that you would look at the other sequences and also always look for the contrast sequence as well, because sometimes certain intramedullary brain tumors will spinal tumors will can also show some syrinx like cavities in the spinal cord, so that has to be ruled out as well. Other than that, let's go to the other sets of cases. Then we come on to this case. This was also perfect. This is a testicular epidermoid. Usually this is considered a benign finding, but there is some controversy about the management. Some say that they enucleate this lesion and then this goes for a histopathology. But essentially this is considered as a benign mass. But for any mass in the testis, you also have to add that you'll send the patient for tumor markers. So even if it is looking benign, it is always suggested, it's always recommended to do the tumor markers, that is LDH, then beta HCG, as well as alpha fetoprotein and all those tumor markers, just to rule out seminoma and other testicular tumors. And even if you're finding this to be very much benign, which I agree, you have the Doppler along with the ultrasound. Always say that you will do the Doppler. You'll put color and see the lesion just to confirm, just to be sure, just to be safe. RCR is actually looking for safe radiologists. They are not looking for someone who's very hi-fi or someone who's a super specialist in any field of radiology, but they're just looking for someone who is safe. So we have to be safe radiologists first. So even if a normal practice will always put color, so please do that. This again, very well done. This was a ruptured dermoid. Regarding the anatomy, why were you not sure which location this is in?
I was confused. This is the inside the lobe, or it's
you can always say it's in the right parasagittal basifrontal or region, or in the right anterior frontal region. You can just be vague about it if you don't know. It's better to be vague about it than to just tell them that you don't know where the lesion is, because that shows that you're not good at anatomy, which we all are good at, because we were all passed FRCR part 1 anatomy. So because what happens if you're not saying this, they'll go back to anatomy. They might start testing your anatomy. Then it's not good for you. So it's always better to be vague about it rather than to say that you don't know the location. I just showed the MRI, the T1 images, just to show it to the rest of the participants. So this was good. And let me see which the other cases was. This was the first case, again a warm-up kind of a case. This is essentially a rapid case. There is elevation of the anterior fat pad, and the posterior fat pad of the elbow, which is not usually seen in normal cases, is seen here. So that signifies that there is some kind of elbow effusion here, which will signify that there is some occult fracture. Even if the fracture is not seen, we would treat this as a fracture and inform the referring clinician or the orthopedician urgently. So just for knowledge, just for revision, this has been discussed before. In a skeletally mature patient, in a case of elbow effusion, what fracture is the most common fracture?
supracondylar.
Supracondylar, you're correct. And in an adult patient with the same findings of elbow effusion, what would be the most common fracture?
Radial head.
Yeah, radial head. That is perfect, correct. This again, well done. This also is rapid, but again can be given in the viva. So this is the fracture of the base of the fifth metatarsal. What is this fracture called?
It's beyond the articular space, so it's Jones, not avulsion.
Yeah, that you are correct. Let me go on to the other images. This I just showed you the scout, and that was enough. In earlier days, before CT came into real existence, or CT was became popular actually. They used to diagnose Sturge-Weber or gyral calcifications in skull radiographs itself. So you can see how beautifully we can see this gyral calcifications. And when we go on to the CT scan, there are extensive gyral calcifications and significant cerebral
Bilateral.
atrophy. And on the left side, you can also see enlargement of the ipsilateral choroid plexus. It is an advanced case, and there is development of some gyral calcification on the right side as well.
Yes.
So we've done this case, and I think we've left with one case. This one, right? So this again was, you did this case perfectly. I would have given you an 8 out of 8 if I were your examiner. You described the findings very well. You said that they are pointing away from the joints. You completed the case with the MRI findings, that you'll tell that the cartilage cap is more than 1.5, that you'll be worried about such a finding. So everything was perfect about this case. So this is a case of diaphyseal achalasia, and I think you were not sure about one thing. I asked you if diaphyseal achalasia occurs together with N-chondromatosis. What is it called? So it is called metachondromatosis.
Okay.
So I don't think the discussion will reach to a level of metachondromatosis, but this is a case. A metachondromatosis is a case in one of the John Curtis's books, which I remember reading. So just remember that. Suppose if they show you such a case along with a hand radiograph with multiple enchondromas, so you should know this. Other than that, well done. I am pleased with you. You are clear, you're confident. You always ask for previous images. That is good. You have good knowledge, and your speed is perfect. Regarding the management, in some of the cases, just like in this case, you were perfect in completing the management, but then sometimes you forget about the management. So
Yes.
do not forget in the exam. And one thing also pleased me about you is that you tell the clinician, you call the clinician and tell them about the findings urgently whenever there is an emergency. So these are the things which actually are borderline things. If you don't say that you'll urgently, the word urgently or the word emergently, so urgently is a word to remember. So just say that, and that actually will help you gain half a mark or 1 mark more. So other than that, well done, perfectly tackled. All the best for your exam. And we'll continue our sessions tomorrow. Tomorrow we'll continue our session at 8 p.m. Dr. Swati, would you like to add anything for candidate 2, please?
No, candidate 2 she did very well. As you had rightly pointed out, only the management part she has to speak about, because we've been kind enough to stop at that this thing. But in the exam, the case does not end until and unless you talk about the management. So yes, as rightly pointed out, just remember one thing: you have to go with certain proforma, and don't deviate from it. Like, don't deviate and don't omit certain things which are must, for you to score in for that particular case. Well done. You have done very well. All the best.
Thank you so much, Dr. Swati, and thank you so much, candidate 2.
They are saying that there are 2 more cases which were not discussed, but I cannot remember. They said the one with splenomegaly and something.
Yes, you are correct. So the one with
EES,
you are correct. This was diffuse esophageal spasm. I wanted the word corkscrew esophagus from you, which you correctly spoke about. So that was good. The diagnosis was enough. And then this case, again, yeah, this is a very important case. You identified all the positive findings. You saw the H-shaped vertebra. You saw the diffuse skeletal sclerosis. You found the avascular necrosis of the right femoral head, as well as, after prompting, you did identify the enlarged spleen. But you were correct in doubting that this could be the stomach. So that is good enough, and this is a case of sickle cell anemia. So you can be given an abdominal X-ray, but you also can be given a chest radiograph of sickle cell anemia, where you can be shown snow-capped humeri or avascular necrosis of the humeral heads along with absent spleen.
Yes.
on the left side, and H-shaped vertebra in the thoracic spine. So these are the findings which can be shown. You can also be shown some patchy opacities in the lungs. That is also seen in sickle cell anemia. So maybe I'll show you a chest radiograph in the coming sessions. Other than that, you did very well in almost all the cases. Perfect, excellent, well done. All the best. And thank you
Thank
to
you.
everyone else. And thank you, Dr. Swati.
Thank you very
Yes.
much.
Thank you.
Thank you.